So good morning again. So this is second part of the pharmacology lecture, and as I mentioned, there's going to be a part three where we're looking at the medication we use in conscious sedation. All right, so we're going to start with the antiarrhythmic agents, and these antiarrhythmic agents they suppress arrhythmia or can terminate arrhythmias. And again, remember, arrhythmia are just abnormal rhythms. So when we talk about abnormal rhythm, we can divide them into what we call supraventricular arrhythmias, and then you can have also your ventricular arrhythmias. Supraventricular arrhythmias, of course, you have your PACs. You can have things like uh, atrial fibrillation, atrial flutter, AV nodal reentry tachycardia, atrial tachycardia, those are some of the supraventricular arrhythmias. Then ventricular arrhythmias, you have your PVCs, your ventricular tachycardia, ventricular fibrillation. So those are the more common um, arrhythmias. Now, again, as we said, these antiarrhythmics are going to suppress the abnormal rhythms of the heart, and we divide them into supraventricular and ventricular, as outlined here. So the agents that we use, we put them in a table form, or we classify them. And this classification is called the Singh-Vaughan-Williams classification, or just a lot of people say the Vaughan-Williams classification, but it's actually the Singh-Vaughan-Williams classification. And we have 5 classes, okay? Class 1 agents interfere with the sodium channel. So we call them sodium channel blockers. They interfere with the sodium channel. That's a class 1 agents, the broad category. Class 2 agents are what we call sympathetic nervous system agents. So the beta blockers and stuff like that. That's a class 2 agents. Then the class 3 agents, they affect potassium efflux, or potassium channel blockers. That's a broad classification. Class 4 is your so-called calcium channel blockers. And then your class 5 agents, the mechanism is not really known. So if you break them down into class, you just have to know in each class what is the general effect. Again, class 1, sodium channel blockers. 2, anti-sympathetic. 3, your your potassium channel blockers. 4, your calcium channel blockers, and then 5 is your mix. This is a very busy, hard to read slide, but this categorize the agents depending on the class. So if you can make out your class, so in your class 1, you have your class 1A, your class 1B, and your class 1C. And breaking them down like this is very important, because you will see that some of the medication that you know is in some of these categories. So you remember, again, your class 1 is your sodium channel blockers, but you have your 1A, and your 1A includes your, let's highlight these a little bit. So your 1A includes quinidine, procainamide, and disopyramide. So these are relatively old drugs, not used much today, but quinidine, procainamide, and disopyramide. These medications affect the QRS complex, and then when you use them, you can see that the QRS complex widens. Okay, so these are sodium channel blockers, and we use the 1As mainly for ventricular arrhythmias. We use them mainly for ventricular arrhythmias. However, your quinidine and procainamide, Sometimes we use them for atrial fibrillation. So then your class 1B, the class 1B includes lidocaine, phenytoin, mexiletine, and tocamide. Okay, uh, we don't use these medications much anymore. We used to use lidocaine quite extensively, and we used to use phenytoin to some extent. Um, these medications are used in ventricular tachycardia as well. Okay, sodium channel blockers. Okay, so your 1B, lidocaine, phenytoin, mexiletine, and tocanamide. Then your 1C, we still use the 1Cs. Again, they're sodium channel blockers, but your 1C includes enconide, flecainide, propafenone, and morizicine. The ones that we still use is the flecainide and propafenone. Okay, so those are still used, and we use the 1Cs mainly for paroxysmal atrial fibrillation. Okay, so we use them mainly for AFib. So you will see flecainide and propafenone used. We stopped using enconide because um, we there was a study that was done that showed that if the patient have reduced ejection fraction, then enconide was causing mortality. So patients were dying more on the drugs, that's enconide, if they had depressed LV systolic function. So we don't use enconide anymore. But you'll still see patients with flecainide and propafenone, especially if they have normal LV systolic function. All right, so these are your 1A, B, and C sodium channel blockers and the clinical use. Your class 2 is the beta blockers. So these are your so-called anti-sympathetic drugs. So beta blockers is in your class 2. And of course, beta blockers includes your propranolol, esmolol, timolol, metoprolol, atenolol, and bisoprolol. So these are some of the beta blockers in use, class 2. And we use beta blockers in almost any type of tachyarrhythmias, supraventricular tachycardia. Patients who have atrial fibrillation, atrial flutter to slow the ventricular response will use these beta blockers. And we use them in patients who have a heart attack to reduce mortality. Okay, this is your class 2. Then your class 3, which we use quite extensively, your class 3 is your potassium channel blockers, and that include, even though we say potassium channel blockers, they usually have a mixed effect. So it's not just only potassium channel blocking. Some of these medications will also have beta blocking properties, and they include your amiodarone, sotalol, ibutylide, dofetilide, dronedarone. So these are your class 3 agents. We use amiodarone, sotalol quite extensively. Dofetilide, which the other name for that is Ticosin, we use that to a fair extent as well. So your class 3 is your your potassium channel blockers. Okay, but some of these, like sotalol and amiodarone, have beta blocking properties. Okay, so these medications we'll use in Wolff-Parkinson-White syndrome, atrial fibrillation, for not only suppressing the ventricular response, but to convert these patients back to sinus rhythm. So atrial fibrillation, a flutter. Um, Very important. If someone has what we call Wolff-Parkinson-White syndrome, and I'll go over that separately with you guys. If they have Wolff-Parkinson-White syndrome, you don't want to give a medication that's going to block the AV node. You want to give something like a procainamide, um, and probably something like an amiodarone, because if you give someone with Wolff Parkinson White syndrome a medication that's going to block the AV node, they will use the bypass track, and the ventricular response or the ventricular rate can become very, very fast, and the patients can develop ventricular tachycardia and death. So when we talk about Wolff Parkinson White syndrome, these patients have a what we call a bypass track that bypass the AV node. If you remember your normal conduction system pathway, the AV node tend to slow conduction going from the atrium to the ventricle. And that is a protective mechanism that we were born to it. However, if you have Wolff Parkinson White syndrome, you have an abnormal connection between the atrium and the ventricle. So you bypass the normal slowing mechanism in the AV node. So if you have, say, atrial fibrillation, when you have atrial fibrillation, the atrial rate is probably 400 to 600 beats a minute. But the ventricular response, because of the slowing property of the AV node, is usually 140 to probably 160 beats a minute. If you didn't have the slowing mechanism in the AV node, then that 400 to 600 beats a minute in the atrium would all go to the ventricle. And if the ventricle beats 400 to 600 times a minute, it's like it stands still. So there's no blood pumping to the brain, no blood pumping anywhere, and you will die. So patients with Wolff Parkinson White syndrome, they have a bypass track that bypass the AV node. So if you give, say for instance, those patients develop atrial fibrillation, and you give them a medication that blocks the AV node, then almost all the transmission or the conduction is going to be through the bypass track, and those patients will collapse right in front of your face. So the only safe medications is your procainamide and probably amiodarone. Your class 4 antiarrhythmics, the Vaughan Williams classification, class 4 is your calcium channel blockers, which includes your verapamil and your diltiazem. We give verapamil and diltiazem in patients who have atrial fibrillation, atrial flutter, to slow the ventricular response. Okay, these medication will slow the ventricular response. They act on the AV node, and slow the amount of impulse going to the ventricle. And then your class 5, which is essentially, your class 5, which is essentially a mixed bag. We're not, they have multiple mechanisms. Your class 5 includes adenosine, digoxin, and magnesium sulfate. Of course, we use adenosine if patients have any type of what we call, if they have any recurrent arrhythmia. So if they have stuff like atrial tachycardia, you can give them adenosine. So any type of re-entrant arrhythmia, you can give them adenosine. So if the patient has, say, AV nodal re-entry tachycardia, we can give them a rapid injection of adenosine, and they convert right there in front of you. So AV nodal re-entry tachycardia. Digoxin, we can use digoxin in patients with atrial flutter, atrial fibrillation, just to slow the ventricular response. That's all it does. And then magnesium sulfate in patients who have torsades de pointe. So torsades de pointe is a multi-form ventricular tachycardia. You can give injection of magnesium sulfate, and that will convert these patients back to normal. So these are your antiarrhythmic drugs, and you should be familiar with the more common ones because we use them quite extensively in cardiology. All right, then we're going to move on to your so-called statin group of drugs, which is your HMG CoAs reductase inhibitors. So these are the common statin drugs that we use patients who have elevated LDL cholesterol. So how does these medication works? So the mechanism of action of your statins or your HMG CoAs reductase inhibitors, it inhibits the enzyme HMG CoAs reductase. Now this enzyme is very important or is necessary. This enzyme is necessary in the conversion of your LDL cholesterol. If you remember, we in your cholesterol cascade, you have your good cholesterol, which is called HDL cholesterol, high density lipoprotein. And then your bad cholesterol is your LDL, low density lipoprotein. So, those are when you break down your cholesterol, you have a good cholesterol and your bad cholesterol. Now, when you have elevated LDL cholesterol, those LDL cholesterol, and again, cholesterol is manufactured in the liver. The bad cholesterol is oxidized. Okay, so you have good and bad cholesterol in the circulation, but your bad cholesterol is oxidized, combined with oxygen, and is oxidized. And that oxidized LDL or bad cholesterol is taken up in the wall of the blood vessels to form plaques. So that's how you form plaques. Taken up in the blood vessel wall, and you form plaques, and those plaques gradually increase to cause blockage. Your good cholesterol sort of reverse that process. So that is why you want to have an elevated HDL cholesterol, which is a good cholesterol, which retards that process. And you want to reduce the bad cholesterol because once it becomes oxidized, it's going to form the plaques. So your statins or your HMG CoAs reductase inhibits the enzyme that manufactures these bad cholesterol. So it's going to decrease hepatic, that is liver production of these bad cholesterol. And what are some of the medical uses? Of course, we use it to treat high cholesterol, high LDL cholesterol, to be specific. Patients who have any pre-existing cardiovascular disease, they may have had a stent, they may have had a heart attack or something like that. These patients have shown you that they have already started the process where the LDL is oxidized, taken up into the arterial wall, and they form plaques. So you want to reduce the LDL cholesterol. Or you want patients who are high risk of developing blockages, your patients who smoke, diabetics, high blood pressure, or a family history. You want to get these individuals relatively early. Again, it lowers the LDL cholesterol, low density lipoprotein cholesterol, which is manufactured in the liver. So what are some of the adverse effects of these statins? Since they're so good, what are some of the problems associated with them? They can increase the liver enzymes. So essentially, they can affect the liver. So the recommendation is to get a liver function test at least once a year. If it's abnormal, you might want to stop the medicine or reduce the medicine or get these tests a little bit more frequent. Commonly, these medicines called myalgia, that is muscle cramp and pain. A lot of patients will stop I will stop taking the medicine because of muscle aches. It can also cause rhabdomyolysis, where the muscle cells actually break down. And when you do blood tests, you'll see evidence of muscle breakdown. Your so-called CPK uh, will be elevated. Okay, these are muscle enzymes. Uh, some There's some suggestion that it may cause cognitive loss. You may get a neuropathy, hepatic and pancreatic dysfunction, and sometimes sexual dysfunction as well. So these are some of the common statins in use. Atorvastatin, traded as Lipitor. Okay, it is actually synthetics, and it inhibit the HMG CoAs reductase and hence reduce LDL cholesterol formation. Servastatin, we no longer use it. It has been withdrawn from the market. It's so-called Baycol, so it's no longer used. Fluvastatin, traded as Lescol, still in use to a small extent. Lovastatin, probably the one that's been around the longest. The other name for that is Mevacor. Then we have, we don't use that much. The other ones are, you have your Pravastatin, Pravachol, Rosuvastatin, Crestor, Simvastatin, Zocor. Okay, so these are some of the more common statins, and the reason for reducing or stop taking the statin is myalgia, muscle cramp or ache, rhabdomyolysis, where the muscle breaks down, and you can get renal failure from that, or it may cause liver abnormal liver dysfunction. So those are some of the more common problems associated with your statins. This show the statin equivalent dose. Your Crestor and Atorvastatin at a much smaller dose tend to be more effective. So you like a Rosuvastatin, which is Crestor, 5 milligrams, will probably have the same effect as a Pravastatin 40, Lovastatin 40, Fluvastatin 80, and Atorvastatin 10. So this equivalent doses. We usually try to get to the maximum dose of the statin, the dose that was used in the studies to show the effect. So for Atorvastatin, we usually try to get to 80 milligrams. Okay, so there's a maximum dose. Lovastatin, 80 milligrams, Pravastatin, 80, your Zocor or Simvastatin, 80, and then the Rosuvastatin, 40 milligrams. So these are the doses that was shown to have maximum effect in the studies. So in clinical practice, we always try to mimic the dose that were used in the studies to show effectiveness of these medications. So that's rational. All right, so we're going to look at some chemotherapeutic agents, just because these agents can cause cardiomyopathy. These medications can affect the heart muscle and weaken the heart muscle. And that is why we get a lot of patients coming to the echo lab. They need to get an echo before they start cancer therapy. We see a lot of patients who are going to start cancer therapy for breast cancer, for example, coming to the echo lab to get an echo, because you need to know what their ejection fraction is before, during, and after treatment. One of the medication that is problematic in that respect is your Adriamycin or doxorubicin, it can cause a cardiomyopathy. It can weaken the heart muscle. So it works by intercalating the DNA in these muscles and cause inhibition of the macromolecular biosynthesis. So it is it prevents cell proliferation. So anything that interferes with the DNA and macromolecular biosynthesis is going to prevent cell replication. You know, with a cancer, the problem is that the cells replicate too much and they duplicate, and you know that's how they cause problems. So we use doxorubicin or adriamycin in patients with leukemia, Hodgkin's lymphoma, cancers such as bladder, breast, stomach, lung, ovaries, thyroid. We also use in multiple myeloma. We see a lot of cases coming, patients with breast cancer, okay, breast cancer. And we need to know the ejection fraction before, during, and after therapy. So what are some of the adverse effects of your doxorubicin or adriamycin? Heart damage, which is top, which is very, you know, this is the one that we are concerned about. It almost always, above a certain dose, almost always cause some amount of heart damage, and the patient will develop a cardiomyopathy. And the cumulative dose that you're concerned about is anything greater than 550 milligram per meter squared. So anything, you know, probably 450 to 550, anything greater than that, you have to think in terms of a heart muscle damage. You can also get what we call typhlitis, which is a life-threatening infection of the bowel from that, nausea, vomiting, neutropenia, any cells that replicate a lot, it can reduce those cells. So you can get a neutropenia, a reduction in the neutrophils in the blood. Can also cause some arrhythmia and discoloration of the urine red. So how does so that's your adriamycin, doxorubicin. That's the sort of prototype, you know, medications that's going to damage your heart muscles. You have to evaluate your ejection fraction. Now we move on to dobutamine, and the reason why we need to know about dobutamine because we use dobutamine in stress tests. So for echo, we do a lot of dobutamine stress tests. So for patients who cannot exercise on the treadmill or the bike, or if they have certain pathology that requires a dobutamine, a non physical stress test, then you can do a chemical stress test. So how does dobutamine work? So we use dobutamine to increase the heart rate and contractility. So it stimulates the beta adrenergic, the beta adrenoceptor receptors on the heart muscle. So the heart. So when we stimulate these beta 1 receptors on the heart, it increases not only the heart rate but the contractility of the heart, and that is why we use dobutamine in stress tests so as to increase the heart rate, because it works on these beta adrenoceptor receptors, and it stimulate these receptors, so you get increase in the heart rate and contractility, and hence the cardiac output. So if someone, so we use it for pharmacological stress tests, but therapeutically, if someone has a reduced ejection fraction and they're in heart failure, and we have them in the intensive care unit, we can use dobutamine to increase the contractility and the cardiac output. So we can use it in patients with systolic heart failure or heart failure with reduced ejection fraction. What are some of the adverse effects of dobutamine? It can cause hypertension or hypotension, both. So hypertension. It can give rise to angina because the oxygen demand, you can increase that. So a patient can develop angina, which is chest pain because of decreased blood flow to the heart muscle. You can get arrhythmia, so look out for that. The patient may develop PVCs, ventricular tachycardia, even ventricular fibrillation. So be careful about that. So atropine is very important to us in cardiology. We use atropine quite extensively. When you're doing a dobutamine stress test, if you max out on your dobutamine and the heart rate is not a target, you can give the patient atropine, which will increase the heart rate. Right? So you give atropine, and the patient will usually increase their heart rate and achieve target. We also use atropine in patients who have significant bradycardia. The patients have a heart rate less than 40, and the blood pressure may be falling, stuff like that. You can give atropine to increase that. In the cardiac cath lab, we use atropine to some extent because a lot of time when we start to work, especially in the groin, and we're doing our catheterization procedure in the groin, the patient will vagal. That is, they'll develop they'll have increased vagal output. So if you remember what the vagal nerve does, it's going to lower the heart rate. So the heart rate is going to drop, and the blood pressure commonly falls as well. And the patient, you're doing your catheterization procedure, the patient tell you they feel sweaty, they feel nauseous, they feel dizzy. So all you do, you just take out your atropine and you inject your atropine, and they revert back to normal. So we need to know a little bit about atropine. The mechanism of action. Atropine is an extract of the belladonna plant. It antagonizes the muscarinic acetylcholine receptors, or the parasympathetic nervous system. The parasympathetic nervous system, the parasympathetic. So the nervous system is divided into your parasympathetic and your sympathetic. The parasympathetic nervous system tends to slow the heart rate. Okay, so that is when you do you're doing a catheterization procedure. That is what's happening. The parasympathetic nervous system is stimulated, so that's why the heart rate will fall. So you give something to block it then. Okay, so it's going to antagonize it's antagonistic to the parasympathetic nervous system. So you'll get a reverse response. Atropine dilate the pupils. When you go into the ophthalmologist, sometimes they use something similar to atropine, or sometimes use atropine to dilate the pupil to look at the back of the eyes. Again, we say to increase the heart rate, and that's what we want, especially when you're doing a stress test, or if the patient develop a vagal response in the cath lab. And atropine reduces salivation and other secretion. So patients who are poisoned with nerve gas, they usually use some atropine derivative to counter that, because a lot of times these nerve gases produce tremendous secretion, and you can drown in your secretion. Okay. All right. So what are some of the medical use for atropine? Again, it dilates the pupil for ophthalmic examination. So the ophthalmologist can look at the back of the eye, look into the retina, and see what's going on. We use it to treat iridocyclitis, to sort of paralyze the iridocyte, the muscles in the eye, so that it doesn't contract and relax and then cause pain. We use it to treat bradycardia and heart blocks, as mentioned, because it increases heart rate. So second degree heart block, second degree AV block type 1, and some third degree AV block. We usually talk about infranodal and supranodal blocks. The reason why it's not effective in infranodal blocks because there's no vagal fibers down there. So the atropine is not going to work at all. However, supernodal, and when we talk about node, we're talking about the AV node. If the complete heart block is above the AV node, then it's very effective because there's no vagal fibers below the AV node. And again, whenever you have excessive secretion, you can use your atropine. So hyperhidrosis, you can use it. Again, so if you have organophosphate poisoning with, say, insecticide, nerve gases such as sarin, okay, you can use atropine to drop the secretions. Okay, so what are some of the adverse effects of atropine? Because it can increase the heart rate, you can get supraventricular tachycardia, you can get ventricular tachycardia, ventricular fibrillation. Patient may be dizzy, nauseous. So you have to look out for these effects of your atropine. But atropine is used quite extensively. It may cause blurred vision, confusion, hallucination. The antidote for atropine is physostigmine and pilocarpine. So you know that. What about persantin? Again, we use persantin. The importance of persantin to us is stress test again. We use persantin in doing stress tests. So it's a chemical agent. So if the patient cannot exercise for some other reason, and you can't use dobutamine or you don't have dobutamine, you can use persantin. So the mechanism of action of your persantin, it inhibits your what we call phosphodiesterase. That's an enzyme, and when it inhibits the phosphodiesterase, it increases the level of adenosine. So when you inhibit the phosphodiesterase, it increases adenosine. So the effect of persantin is really the effect of adenosine, because since it's going to block this enzyme, you're going to get an increase in adenosine. Okay, so that's how it works. And you get a block of platelet response to ADP. But the important thing is that it results in, it inhibits the cellular uptake of adenosine. And as a result of that, you get a buildup of adenosine. Adenosine will cause vasodilatation. So what are the medical uses? Chemical stress tests. So the most important thing for you guys is the stress test. There are some studies that show that it may prevent stroke or TIA when combined with aspirin. And we have a combination of persantin with aspirin that is used in patients with to prevent our patients who have had strokes or TIA. So the adverse effects of persantin, we tend to, if the patient have bronchospasm, patient is asthmatic, you have to be very careful because your persantin can cause bronchospasm and the patient can start wheezing. Okay, they may get flushing because it causes, you can get vasodilatation, you get flushing. Again, as we mentioned, the effects of persantin is really adenosine because it blocks the reuptake of adenosine. So if you know the effect of adenosine, you essentially know the effect of persantin. The essential difference between giving persantin and adenosine, if you're going to use adenosine in your stress test, the effects of adenosine last a few seconds, whereas persantin is much longer acting. So you can get significant bradycardia and heart block with your persantin, and this may last for a little time, may last a little long. But if you use adenosine, these effects are very short-lived because the duration of action of your adenosine is with a few seconds. So the mechanism of action of adenosine, it's a purine nucleoside, and there are 4 types. of receptor for receptor subtypes. You have A1, A2A, A2B, 3. Just know that there are 4 types. Mechanism of action of adenosine: it inhibits your adenylyl cyclase. Okay, so it causes vasodilatation, the same thing as we mentioned for persantin, because persantin is going to produce its effect through adenosine. So adenosine inhibit your adenylyl cyclase, cause vasodilatation. You get transient blocking the AV node. Okay, so it's not going to be as pronounced as your persantin because it's the duration of effects of your adenosine is only a few seconds. So you get very, very transient AV block. So you'll see when you're doing the stress test, the patient may become asystolic for a couple of seconds. So, don't get, they're going to always come back with their rhythm. All right, so what are the medical use for adenosine? We use it to terminate supraventricular tachycardia, commonly your AV nodal reentry tachycardia. So again, the patient would come in to the emergency room, heart rate 180 beats per minute, 200 beats per minute, blood pressure is falling. You rapidly give them adenosine and it just breaks the rhythm. Okay. And of course, we use it for pharmacological stress tests. Okay, it's one of the important armamentarium that we have for our chemical stress tests. So the adverse effects include facial flushing, lightheadedness, diaphoresis, nausea, metallic taste in the mouth, transient asystole. So don't panic. They always come back with their rhythm. And of course, if they're asthmatic, they may develop bronchospasm. So those are the medications that we discuss in the second part of our pharmacology lecture. We still have to go over the medicines that we use in moderate sedation. Those are the ones that you have to be very familiar with because we're going to use them to do a cardioversion, electrocardioversion, or transesophageal echo on a cardiac catheterization procedure. So you need to know how these medicine works, what are the adverse effects, and how to manage the patients when you have complications secondary to these medicine. So there's going to be a third pharmacology session where we go over